Imagine the most arrogant, self-obsessed person you know, the one who constantly talks down to people, the one who demands special treatment and seems completely convinced of their own absolute perfection. Now, imagine that same person sitting in a therapist's office, secretly crushed by shame and begging for help. It sounds impossible, but it actually happens. And here is what makes it even stranger. A study from 2025 tested 180 trained mental health clinicians, shown a classic arrogant patient. 97% of them spotted narcissism instantly, but shown a vulnerable, anxious, deeply ashamed patient with the exact same disorder, only 24% recognized it. 3 out of 4 professionals were completely fooled, not by a clever actor, but by the disorder itself. There is more. Patients with this condition can literally rewrite their own memories mid-conversation, erasing a failure 5 minutes after it happened. Some of them devalue the very therapist trying to save them. And yet, in rare moments of collapse, they see themselves clearly, and that moment might be the only window to help them. What you are about to hear will shatter the cultural caricature of narcissistic personality disorder, or NPD. Because the condition that makes people act completely flawless is, in reality, a desperate cover-up for an incredibly fragile self. But before we can understand why they want help, we have to accurately understand what it is they are actually suffering from. The popular image of a narcissist is just someone who loves themselves too much. But the clinical reality is vastly different. There is a whole medical guideline for this, the DSM-5-TR, the official diagnostic manual. It outlines 9 specific traits for a diagnosis, and you need to meet at least 5 of them. These are the traits we usually associate with the label. An inflated sense of self-importance, fantasies about unlimited power, a constant need for admiration, a deep sense of entitlement, arrogant behavior and that tendency to use other people to get what they want. But here is the thing. Experts in the field emphasize that this official definition only captures the loud, showy side of the disorder. It completely misses the hidden side. Researchers now understand that there are actually 2 faces of NPD. The first face is the one we know, the grandiose face. Clinicians often describe this as the thick-skinned presentation. This person is arrogant, dominating, endlessly charming when they need to be, and quick to take advantage of people. But then there is the second face, the vulnerable or thin-skinned narcissist. And this is the side that is secretly ashamed. They feel inferior. They are intensely sensitive to any kind of criticism, and they get incredibly easily hurt. And it is rarely a case of a person being completely one or the other. They do not just pick a lane. People with NPD frequently flip back and forth between these 2 states. One day they are riding high, feeling invincible, completely convinced of their own brilliance. The very next day, a minor slight, maybe an email from a boss that just was not enthusiastic enough, can trigger a total collapse. Suddenly, they feel utterly worthless, which brings up a massive misconception. The common belief is that narcissists have 0 empathy, that they just do not care about anyone else's feelings at all. But clinical research shows that is not exactly true. They do not completely lack empathy. They can often perfectly understand what other people are feeling, but they struggle to act on it, or they actively choose not to, because engaging with someone else's emotions feels threatening to them. It feels unsafe. And this changes everything about how we view the disorder. The lack of empathy is not a biological inability to see you. It is a psychological defense mechanism, a wall to protect themselves from feeling vulnerable. Think of it as a medieval castle. The grandiosity, the bragging, the arrogance, the charm, that is the giant stone wall and the moat. But the vulnerable side, the shame and the fear, that is the terrified king hiding down in the basement. And we only ever see the wall. We just see the fortress. And here is where that image gets dark, because that wall does not just keep enemies out, it keeps the king trapped inside. The defense mechanism becomes a literal prison. But if that grandiosity is doing such a great job of protecting them from the shame, why would they ever give that up? No one willingly walks out of a fortress if they think they are under attack. That is the core question. They rarely, if ever, walk into a clinic and announce, "I am a narcissist, please cure me." That just does not happen. Instead, they seek help because the wall is crumbling. The fortress is collapsing on top of them. The life around them falls apart. A spouse finally gives an ultimatum: get into therapy or the marriage is over. Or they get fired from a high-stakes job because their inability to handle constructive criticism finally crossed a line. Their life systems begin to fail. And often they come in because the acute pain of secondary problems gets too loud. Many people with NPD seek treatment for severe depression, anxiety, addiction, or even suicidal thoughts, because those issues frequently ride alongside the personality disorder. It is that immediate pain that gets them in the door. Keeping that wall up 24/7 is physically and mentally exhausting. The clinical literature talks about how the mask gets heavy. Pretending to be absolutely perfect every single day requires a frantic, constant effort to monitor how everyone perceives you. You have to hide any perceived flaws. It is an exhausting and deeply lonely way to live. So eventually some of them just want the performance to stop, which leads to moments of clarity during a vulnerable collapse. When that confident, grandiose front shatters, they can suddenly see their own destructive behaviour. And therapists note that these vulnerable moments of collapse are often the best and sometimes the only window to start treatment. Because when they are in their grandiose state, they feel fantastic. They see no problem at all. The suffering only registers when the mask slips. But what does that collapse actually look like in practice? Reading about the two faces of narcissism is one thing, but seeing them clash in real time is something else entirely. There was a case study in the clinical literature about a patient they referred to as MSC. MSC initially came into treatment reporting that she felt deeply insecure around other people. She was terrified of rejection. She presented to her therapist as incredibly fragile and anxious. But after a few months of building trust, she finally admitted her secret. She confessed that internally, she constantly judged everyone around her as incompetent and stupid. She desperately wanted to feel superior, and she spent her time fantasizing about becoming a world-famous artist, just to prove to the world that she was better than all the people she secretly looked down on. It is a striking mix, because the fear and the shame were real, but the grandiose fantasies of crushing everyone else with her brilliance were real too. Both faces of the disorder existing in the same person at the exact same time, battling each other. But if the whole disorder is fundamentally built on believing you are perfect, how does someone mentally justify asking a professional for help? Does seeking help not mean admitting you have a flaw? That is what clinicians call crisis motivation. They are not going to the therapist saying, my personality is broken. They are saying, my wife is being unreasonable and leaving me, or I am depressed because my boss doesn't recognize my genius. The motivation to get help is entirely driven by the immediate crisis, and they often frame themselves as the victim of circumstances or other people's incompetence. So the challenge for the therapist is trying to transition that temporary crisis motivation into a genuine long-term commitment, which is incredibly hard because they are sitting in the therapist's chair motivated by a crisis, but the therapy itself is a threat. Why is it so difficult to treat? They are smart. They are in the room. They want the pain to stop because treatment fundamentally requires dismantling the very defense mechanism that is keeping them alive. Think about it. NPD is a defense system against shame. Good therapy asks a patient to look deeply at flaws, their failures, and their vulnerabilities. It asks them to look at the exact things the disorder was built to hide. It is like going to the doctor for a broken arm, but the broken arm has a mind of its own and keeps punching the doctor every time they try to set the bone. And the punches are not random. The moment the therapist touches the bone, say, by gently pointing out that the patient might have made a mistake at work, the disorder swings back to protect the patient. The patient might suddenly look at the therapist's diplomas on the wall and say, "Did you even go to a good school?" Because I feel like I'm talking to an amateur. You clearly do not understand high-level corporate dynamics. They devalue the professional to regain their own sense of superiority. They attack the person trying to help them to avoid feeling small. And there is another detail in the research about how they handle failure. The The clinical literature notes that patients with NPD will literally rewrite their own history in real time to erase any memory of failure. The researchers compared this behavior to the kings of the Assyrian Empire, who would rewrite historical records after a lost battle to make it look like a glorious victory. In a modern therapy session, it looks like a patient completely denying they said something just 5 minutes prior. If the therapist points out a contradiction or gently corners the patient into admitting a mistake, the patient's brain will edit the memory to protect the ego. They will say with absolute conviction, "I never said that," or "that is not how it happened. You are twisting my words." It is an incredible unconscious defense mechanism. If you cannot handle the shame of a failure, your brain just edits the failure out of your personal history. But you cannot treat a problem if the patient's brain will not even allow them to acknowledge it happened. And add to that the barrier of the label itself. Narcissist is not just a clinical diagnosis in our culture, it is a massive insult. Admitting I have NPD causes immense, crushing shame. Because of all this, the disorder fighting back, the memory editing, the stigma, the dropout rates for NPD are incredibly high compared to other mental health conditions. When a person with NPD comes in to treat their anxiety, the progress is slow, it gets uncomfortable, and they are far more likely to quit. So the patient is fighting the cure. But it is not just the patient. The clinical system itself is struggling to handle this disorder. Which brings us back to that 2025 study of 180 mental health clinicians. The researchers wanted to see how well-trained professionals could spot the two faces of narcissism. And the results were staggering. When the clinicians were presented with a grandiose patient, the arrogant, boastful type, 97% of them correctly spotted the NPD. That is the classic stereotype. But when they were presented with a vulnerable patient, the one hiding in the basement, sensitive and ashamed, only 24% correctly identified it as narcissism. These are highly trained professionals, and more than 3/4 of them are missing the diagnosis. What are they mislabeling these patients as? They diagnose them with depression or trauma responses or borderline personality disorder. And if your diagnosis is wrong, your entire treatment plan is wrong. You are treating a symptom while ignoring the underlying personality structure generating it. Why are they missing it? The study revealed something remarkable about how a patient's disorder can manipulate a therapist's emotions. It is all about what the clinician feels in the room. The studies show that treating grandiose patients made the clinicians feel anger, distaste, and a deep sense of hopelessness. Many openly admitted they just did not want to work with them because it felt abusive. And nobody likes being talked down to for an hour. But the vulnerable patients evoked completely different emotions. They made the clinicians feel intense sympathy and a strong desire to protect them. The clinicians felt so sorry for these fragile, anxious patients that it created a blind spot. It caused the therapist to severely underestimate how sick the patient actually was. They missed the underlying hidden grandiosity entirely. So the disorder is playing the therapist's own empathy against them. It is a testament to how powerful narcissistic defense mechanisms are. They can flatter, test, or attack a therapist so effectively that the professional loses their objective footing. And when you combine that dynamic with the severe stigma from doctors who view NPD as untreatable, the pool of available willing help shrinks dramatically. And the science is lagging behind too. There are no randomized controlled trials for NP, none, zero. And there is no magical pill you can take to cure it. No medications treat NPD directly. A doctor might prescribe something for the co-occurring depression or anxiety, but the NPD itself relies entirely on talk therapy. And because there are no gold standard proven treatment guidelines like we have for other conditions, therapists are mostly relying on case studies and their own clinical experience. So we have a patient whose disorder fights the cure. We have incredibly high dropout rates. We have a systemic blind spot where therapists miss the diagnosis because they feel too sympathetic. And we have a lack of hard science. It paints a pretty bleak picture, but people do get better. Treatment can work, and it relies on very specialized talk therapies. One of the most fascinating approaches is called transference-focused psychotherapy, or TFP. In traditional therapy, a patient might spend the hour talking about their terrible boss, and the therapist helps them process that past event. But in transference-focused psychotherapy, the therapist uses the live interaction between the two-heim laboratory, meaning if the patient starts acting arrogant and talking down to the therapist in the middle of a session, the therapist does not just listen. They pause the conversation and say, "Look at what you are doing to me right now. Why are you trying to make me feel small in this exact moment?" They use the relationship itself to expose the defense mechanism while it is actually happening. They force the patient to look at the armor they are wearing in real time. It is incredibly difficult, but it works to dismantle that identity confusion and grandiosity. And regardless of the specific therapy type, whether it's TFP, schema therapy, CBT, or DBT, the research outlines a few core principles for success. The first one is setting realistic goals that the patient actually wants. You cannot just tell them to stop being arrogant. If the spouse says, "The goal is for you to stop being a narcissist," the patient will rebel. The goal has to be something the patient desires, like, "I want to stop getting fired from my jobs," or "I want to feel less exhausted and anxious all the time." You align the treatment with their self-interest. And a big part of that is avoiding the loaded label. Good therapists often discuss the behavioral patterns extensively without ever dropping the word narcissist into the room, because they know that word triggers the ultimate shame defense. They talk about the symptoms without weaponizing the diagnosis. But there was one clinical secret in the research regarding how the best therapists handle their own emotions, and it is brilliant. It is the part about projection. Top-tier clinicians do not ignore their own emotional reactions in the room. They use their own feelings of boredom or sudden anger or feeling totally useless in a session as a diagnostic tool. Here is what that means, because projection sounds like clinical jargon. If a therapist suddenly feels utterly incompetent and useless during a session, they realize that the patient is actually the one feeling useless deep down. But the patient is projecting that feeling outward. Because the patient is terrified of feeling useless, their subconscious behavior forces the therapist to feel useless instead. The patient might subtly criticize the therapist's methods, or yawn, look at their watch, or sigh heavily, all to transfer that intolerable feeling of inadequacy out of their own body and into the therapist's body. A highly trained therapist will recognize this and think, "Wait, I am a good therapist. Why do I suddenly feel like a failure?" This is what the patient is hiding. It is like emotional echolocation. They are bouncing their own feelings off the interaction to map the hidden trauma in the patient. They use that intense working alliance to slowly turn the initial crisis motivation into a long-term commitment. They have to plan ahead for the inevitable moments when the patient will feel exposed, try to lie, and try to quit, which gives a lot of context to a hopeful comparison drawn in the research, like pointing back 20 years to borderline personality disorder, or BPD. 2 decades ago, BPD was heavily stigmatized. It was viewed by the medical community as completely untreatable. The patients were often labeled as inherently manipulative, and it was seen as a hopeless diagnosis that many doctors refused to touch. But then a specific therapy, dialectical behavior therapy, came along and proved that real, measurable change was actually possible. The mechanisms of the disorder could be managed, and once the medical community saw it could be treated, the stigma dropped significantly. Researchers firmly believe that narcissistic personality disorder is next, so there is real hope. With better education, a reduction in stigma, and more dedicated research into specialized therapies, we can open doors for NPD patients that are currently slammed shut. The practical takeaway here is managing expectations. Progress with NPD means becoming better, much better, but it is slow, it is partial, and it is a gradual improvement. It is not a magical, overnight, perfectly cured state where they never have an arrogant thought again. And for a patient who desperately wants to be perfect right now, that slow, imperfect progress can feel like a devastating failure, which triggers the urge to quit. Sticking with it past that agonizing urge to quit is the ultimate hurdle for anyone with this disorder. We have moved from seeing narcissists as cartoon villains constantly checking their hair in the mirror and plotting to ruin lives, to understanding them as people trapped in a miserable, exhausting cycle. They are bouncing violently between a grandiosity that alienates everyone around them and a crushing shame they are terrified to show anyone. They are prisoners of their own defense mechanisms. The very armor they build to protect themselves is what is suffocating them. And the fact that some of them actually recognize that and walk into a clinic to ask for help, despite knowing how agonizing the process of dismantling that armor will be, completely reframes the narrative. It requires a tremendous amount of courage for someone with this disorder to face the thing they fear most, their own imperfection. Which leaves us with one critical thought. If the absolute worst, most arrogant behavior we see in others is often just a frantic, exhausting shield covering up a deep sense of worthlessness, how does that change the way you interact with the most difficult people in your own life? Keep looking past the surface of human behavior, because the truth hiding underneath is always more complex and a lot more human than it seems.